So today we'll be talking about treatment for macular degeneration. Many of you will have gone through some of the other modules, and you will have most likely gone through the eye exam module, the biology module, and so this for me as a physician is probably the most interesting in terms of how do we treat macular degeneration, hopefully for the betterment of patient care as well as improving vision. And so to review, there's two types of macular degeneration, a dry and a wet kind. The dry macular degeneration is the earlier stage. Everyone first develops dry macular degeneration, and a subgroup, 10%, go on to develop wet macular degeneration. The presence of drusen or age spots, material deposited under the retina, is the hallmark of dry macular degeneration. A certain subgroup go on to develop thinning of the retina, which is called atrophy. Wet macular degeneration is a later stage in which blood vessels grow and leak their blood or simply fluid, which can cause rapid loss of vision in the center part of the retina. Current treatment options for dry macular degeneration includes vitamins. Wet macular degeneration is injections of medication into the eye. Right now, at the moment, anti-VEGF medication in Canada. And then I'll be talking a little bit about research in terms of new treatments that are coming online hopefully soon. So what do vitamins do? So they slow the progression of dry macular degeneration. They don't, unfortunately, improve vision. Injections of anti-VEGF medication are for wet macular degeneration only. They do not help dry macular degeneration. And here's a picture of a patient who has dry macular degeneration. And you can see the multiple drusen, the little spots in the back of the eye. Over time, 10% of people go on to develop bleeding at the back of the eye. This is a picture of a patient with wet macular degeneration. Still later on, more blood is bleeding in the back of the eye, resulting in further reduction in vision, followed by scarring, which provides a stable end result, but unfortunately loss of central vision. Now, your peripheral vision is always good. It is not affected by wet macular degeneration or dry macular degeneration, but your central vision can be affected, so it's difficult to read, drive, recognize faces. Dry macular degeneration can also go on to develop what's called geographic atrophy, which is a thinning of the retina. And so centrally here you can see a spot where there's not really a lot of age spots, and that's where the age spots have actually been eaten away and the retina has become thinned. And in those areas of thinning, the vision is also lost, and so people will notice black spots in their vision. Current therapy includes zinc and antioxidant vitamins. This is good for patients both with dry or wet macular degeneration, and it reduces the risk of progression by about 25%. And so we recommend this for everyone who's got dry macular degeneration of a certain severity, as well as for patients who have wet macular degeneration. The dosage, current dosage, is zinc. Now, of interest, new research has shown vitamin A to be in the same league in terms of helpfulness as lutein. And it turns out that for people who have been smokers in the past or current smokers, that vitamin A can increase the risk of lung cancer. And so the most current recommendations actually has removed vitamin A or beta carotene from vitamins for dry macular degeneration and replaced them with 10 milligrams of lutein. And so nowadays, zinc, 25 to 80 milligrams, vitamin C, vitamin E, copper, and then lutein are suggested. And vitamin A is no longer recommended because of the risk of lung cancer if you've been an ex-smoker or you currently are a smoker. There's a variety of different brands, both generic brands as well as different formulas from a variety of different companies. Now, the thing about the vitamins is that they're fairly high dose vitamin E, and that in itself can lead to increased risk of stroke and heart attack. And so if you have liver troubles or diabetes or cancer or blood thinners, then it would be very important for you to mention to your family doctor that you might be starting some new vitamins because it might interact with some of the other medications you're on. AREDS 2 is the second half of the age-related eye disease study. Part 1 showed that the AREDS vitamins was helpful at reducing the risk of progression. AREDS 2 looked at the addition of omega-3, lutein, and zeaxanthine, and they removed beta-carotene. And what they found was there was no benefit to the omega-3, that the lutein and zeaxanthine was as effective as the beta-carotene, so that beta-carotene could be removed. They also found that a lower dose of zinc seemed to work pretty much as well as the previous 80 milligrams. So just to review again, macular degeneration always starts off in the dry form. In a certain subgroup of people, approximately 10%, it transitions to the wet and then can lead to bleeding and leakage at the back of the eye. VEGF, or vascular endothelial growth factor, is a chemical factor released by oxygen-deprived tissue, and it can lead to new blood vessel growth, which is the conversion from the dry to the wet with these new blood vessels, which tend to be weak and they tend to break and bleed. There's several different types of medication that can be used to stop VEGF. Lucentis is one, Avastin or Eylea, and they're all injected directly into the vitreous inside the eye. Eylea is not yet available in Canada, although it will be available shortly. Probably within a few months we'll be able to get access to it, although it's likely not to be covered by the government for at least a year. So the people that benefit from wet macular degeneration in terms of injections are people with wet macular degeneration. And dry macular degeneration does not benefit from injections into the eye. Studies have shown that monthly injections provide the best result, although it is likely that results almost as good could be attained by injecting medication as needed with leakage being present. If leakage is not present, then often you can hold off. And this results in a fewer number of injections while maintaining good vision. And so the procedure is, you get a consent, we review the risks and benefits. The biggest risk is risk of infection, approximately 1 in 1,000. We confirm which eye is to be injected, we clean the eye, we freeze the eye with some freezing drops, and then we do the injection, and then we rinse out some of the fluid. Now, of interest most recently, we've started to use a new technique of less cleaning solution, and we're hopeful that this will cause less irritation for the eye and that patients will be more comfortable as a result. It also has, we've changed the location of the injection. We used to do it at the 6 o'clock position, and now we use an injection to the side of the eye, either the inside or the outside of the eye, which also may be less painful for people.
In dry macular degeneration, deposits collect underneath the retina. In wet macular degeneration, abnormal blood vessels begin to sprout. A molecule known as a vascular endothelial growth factor, or VEGF, is released in wet macular degeneration. VEGF binds to receptors much like a key entering a lock. VEGF is a signal which causes leaky blood vessels to form underneath the retina. As these abnormal blood vessels bleed, the retina becomes swollen and treatment for wet is an injection of medication into the eye. This medication is delivered close to the retina after freezing and cleaning the eye, and most patients experience only minimal discomfort. These medications work by binding to the VEGF that is released, much like a spring. As a result, VEGF cannot bind to its receptors. These injections slow or stop the growth of abnormal vessels. As with any medical procedure, injections of anti-VEGF may help to preserve or slow the risk of vision loss from wet macular degeneration performed. They last only a certain time, and repeated injections may be necessary to preserve vision. Talk to your ophthalmologist about the benefits and risks of anti-VEGF medication to learn more.
Now, what are the expectations and in terms of injections for patients with wet macular degeneration? Well, it turns out 95% of patients have stable visual acuity post-injection. 40% actually will notice an improvement in their vision. Now that means 60% do not, but it is better than the past, and it's a good start. And with new medications, we would hope that that 40% will continue to improve. Most common serious risk is risk of infection. That's about 1 in 1,000. Irritation and slight discomfort are the more common side effects. This is an optical coherence tomography test. It's a scan using a laser technology to put a thin slice through the retina. Now, this layer here is the actual retina, and there's a pocket of fluid underneath the retina. And you'll notice that before the treatment there's quite a bit of fluid. Post-treatment there's still a little bump, but there's none of that black fluid underneath the retina. So we talked about risk of infection, 1 in 1,000. Very rarely you can get a retinal tear or retinal detachment. You can get some inflammation in the eye, or you might get an allergic reaction to the cleaning solution with irritation, redness, or discomfort. Intravitreal injections of anti-VEGF is the current standard of care, but lots of research is being done to try to improve outcomes. Stem cell therapy has been used to replace the retinal pigment epithelial cells. These cells live underneath the retina. There's a chemical which is used called CNTF, which can be used to revitalize damaged cells. So cells that are sick but not dead can be revitalized with an injection of this medication. And what researchers have done, they've actually inserted a small little cage of transplanted cells from another donor, and actually these cells have been re-engineered to produce the CNTF at high concentrations, and it's felt that the CNTF can protect RPE cells, which are providing nutrition to the photoreceptors. And so that's in research stages. And then gene therapy, in which by changing the genetic materials we might be able to protect cells underneath the retina as well as the retinal cells themselves. And so all of these research techniques are being used throughout the world in an attempt to improve outcomes. To date, nothing is better than the injections into the eye, which are currently available here in Edmonton. Oral medications offer the hope of stopping injections. There's research going on with regards to oral medications to try to replace the injections, eye drops, perhaps vaccinations or combination therapy, as well as radiation, surgical radiation, where you actually operate and put a small radioactive piece just in front of the retina for a few minutes. That can reduce the recurrence of wet macular degeneration. So in summary, there are a variety of treatment options. The key for dry macular degeneration is vitamins. Vitamins include vitamin C, zinc, copper, vitamin E, and lutein. We don't use beta-carotene anymore. Wet macular degeneration is best treated with anti-VEGF injections into the eye as well as vitamins. And then there are a variety of different research protocols, and patients in both Edmonton and Calgary have access to these both now and in the future in terms of the newest treatments. And I just want to thank the Blumenfeld Foundation for funding this educational program.